So my job today is to speak to you about nutrition and vision, and I suppose the function of nutrition for vision. What do we know about this? And I've been fortunate to be studying in this area for nearly 10 years, or for over 10 years now. And you know, it's changed exponentially in terms of what we've been able to learn about the role of nutrition for vision. And I myself did my PhD in Waterford in Ireland. I did a postdoc in Atlanta, Georgia, and Augusta, Georgia. And I'm now happy to be back managing with my colleague Stephen Beattie the Macular Pigment Research Group. Our group is a multidisciplinary group of researchers. Primarily, by the way, we have a lot of optometrists who work towards their own PhDs in our centre. So we use the mix of vision expertise, nutrition expertise, statistics, and all of the above to put together research questions, and we endeavour to answer those research questions so we can contribute to optometry, so we can contribute to science, and so we can make real-life changes in the work that we do. So the objective of my lecture today, I've been given the job to speak about the amount of lutein and zeaxanthin in food. We commonly talk about lutein and zeaxanthin. I'm going to talk to you about the particular foods and what we know about the foods and the concentration of lutein and zeaxanthin in these foods. The amount in foods is one thing, the amount in a diet is another thing. So we know how much may be in a food, but how much of that are we eating? We're going to talk about that as well. I'm particularly going to talk about mesozeaxanthin. Mesozeaxanthin is a relatively new compound in terms of its scientific knowledge. It kind of came on the scene in 2006, and we've been studying mesozeaxanthin at our centre since that time. We're going to talk about mesozeaxanthin in nature, its presence in nature. Is it present in nature? Is it present in foods? Where does it exist elsewhere outside the human macula? I'm going to speak to you about supplements and supplement analysis that we've done in our lab. Eye care specialists, optometrists routinely recommend various nutritional supplements for eye care for promoting eye health. I'm going to speak to you about some of the interesting findings we have in that area. I'm going to do a whistle tour of many of the studies that we've been conducting over the last years in terms of macular pigment, how people respond to it, what we know about that and its implications for visual function, visual performance, all backed up by peer-reviewed scientific publications. And I'm going to make some final recommendations and conclusions. We'll stick to the facts. It can be very difficult, but we would like to keep it almost blue skies and clear. When you look at the eye, you can see that there's many structures, there's many components of the eye. You know them as well as I do. I'm going to speak to you today with emphasis on the macula lutea, because I believe when we speak about nutrition in the eye, this is the area of the eye that holds most relevance in this concept. So I'm going to focus on that. There's many other vitamins and minerals that we could discuss in terms of nutritional health, but I'm going to focus on the macular carotenoids. And here we see it. Here's our macula, as you're all familiar with, your fovea, your foveola, and in the center of that we have this uniquely brilliant and beautiful yellow spot. This is the famous image from Professor Max Notterly's laboratory, and this image essentially shows you everything you need to know about nutrition for the eye. It shows you the specialized location, it shows you that it's central, it shows you that it's at the most important part for visual function, for visual performance. As eye care professionals, we should ask ourselves, why is that there? What does it do? And I hope that I can give you some of the answers to those two important questions today. Zeaxanthin, mesozeaxanthin, and lutein, these are three carotenoids. Carotenoids, there's 600 of them in nature, maybe 700 now that have been identified. 50 in a typical Western diet, 50 in a diet that we may consume. But 3, and only 3, have been selected by nature to be placed in the macula. These are lutein, zeaxanthin, and the central component is mesozeaxanthin. They're structural isomers, which is a scientific term for they're very similar molecules, but they're also very unique and different molecules in terms of their potential functionality, and that's due to the location of double bonds and their orientation in space. We won't get confused by that today, but just know they're similar, but yet they're also unique. And their uniqueness is probably why the 3 of them have been selected to be placed where they are. And we will learn a bit about that today. Casually, we will say to patients, leafy greens, coloured fruits and vegetables. This is what you need to do, but I want to speak to you in more detail about that. fruits and vegetables, as I say. I've picked some papers. I went back to the literature. I read 82 papers in preparation for this lecture, papers that I never thought I would read. And I really got engrossed by the literature in terms of what was there. I've selected a handful, and I'm going to speak through those now. The first paper I'd like to draw attention to is a publication by O'Neill et al. In the British Journal of Nutrition. In this very nice paper, the authors, the researchers, they essentially generated a carotenoid database from many different sources. So they were going to build a table of information around foods that contain carotenoids, particularly lutein. And here you can see some of the sources of that information. In such databases, authors will report the information as milligrams per 100 grams of food. So I want you to think about this for a second. Milligrams per 100 grams of food. So this is exactly weighed out in our lab, 100 grams of food. So if you were to obtain the amount of carotenoids that I'm going to show you, we're going to talk about lutein, you would have to eat this amount of food. So that's 100 grams, the tables I'm about to show you. Here's some of the examples. We say leafy greens. Let's look at it. Broccoli, asparagus, celery, all contain, let's just have a quick look at the numbers. 0.73 milligrams per 100 grams of food. So you would have to eat 100 grams of that food to get 0.73 milligrams. So it's a lot of eating. Here's some other one. Lettuce, parsley. Peas was one that I wasn't, if I'm to be honest, very familiar with. Peas is a very good source of lutein. We'll speak about that a little later. Again, you would need to eat 100 grams of peas to take in 1.8 milligrams. Corn is something that we casually and continually say as a source of lutein. And yes, corn and corn-related products do contain lutein and zeaxanthin. Watercress, look, in this study it showed that it had a lot of lutein, 10 milligrams of lutein. But I would never eat 100 grams of watercress. Maybe you would. Spinach. Spinach is the big one, isn't it? Spinach is something that I think we commonly recommend to our patients. And you can see why, again, spinach is a very good source of lutein. But again, I probably wouldn't eat 100 grams of spinach weekly, daily, monthly, I'm not sure. If you have a think about it for a second. Eggs deserve special mention. And while the content of carotenoid is not as high in egg products as it is in, say, spinach or peas, eggs are very interesting because bioavailability is greatly enhanced in the egg yolk. The reason why the yolk is yellow is because of carotenoid. It's primarily because of lutein. The rule of thumb, maybe multiply the number by 4 or 5 in terms of if you want to kind of quantify how much we can get from an egg. And that's due to the enhanced bioavailability around this nutrient. But in terms of our patients and making recommendations, we've summarized, yes, there's nothing really new. It's leafy greens, colored fruits and vegetables. We know that we need to eat a certain amount of that to take in 2 milligrams, 3 milligrams, up to 6, 7 maybe if you eat a lot of spinach. But the journey just begins then for the carotenoids. The journey just begins in terms of bioavailability. And this looks very complicated because it is. It is complicated. There's a lot going on after we consume a particular food. There's a lot to take in consideration. The food matrix, how it's prepared, how it's cooked. Is it esterified? Is it free? There's all these things that I suppose scientists need to be aware of in terms of understanding response. Because, of course, the objective of the exercise here is to eat a food that can give us a nutrient that we believe is beneficial for eye health. But we need to try and understand bioavailability a little bit. And there's a whole process here. I won't go into it today. I just wanted to bring it to your attention that bioavailability is key. And this comes into play, by the way, as well with supplements. And I'm going to talk about this later, bioavailability of supplements. If we eat a 10 milligram lutein supplement, are we able to bioavail of that? Are we able to digest it? Are we able to break it away from the other nutrients that may be in that multivitamin? So there's a lot of scientific testing that needs to be conducted for full understanding in terms of absorption, uptake, and functionality. We would all like to think that we eat like this lady, leafy greens, yes, and even we go to the optometrist, yes, I do. Go to the doctor, yes, I eat this. But the reality is, it's more like this. And I'm going to show you why. Because I'm going to summarize now what we actually consume in the UK and Ireland and in different parts of Europe. This is a very nice study, actually work from Dr. Alan Howard. And this is what I think has generated his own interest in lutein. And this lovely publication compared two populations of interest in terms of their carotenoid intake. In the UK, it looked at fruit and veg. It saw that fruit and veg intake was much, much lower than that of Toulouse in France. So you can see the numbers there, 85 grams per day of fruit compared to 250 grams per day of fruit in Toulouse. And that's a massive difference. This was in Coleraine in the UK. Let's look at the vegetables. 35 grams per day of veg in the UK on average versus 300 grams per day. So there's a massive difference. So what did that mean? What did that mean to the subjects tested in this trial? Well, it meant a lot. It meant that their lutein level in plasma was less than half. So what we eat absolutely affects what's in serum. And that's the first part of the understanding. Okay, so you have to eat it to get it. Another work, I'm going to go back to the publication by O'Neill again. And remember what these guys did. They developed a carotenoid database. They used many, many sources, and they developed a very nice carotenoid database. And then what they did very nicely was they went to Spain, France, UK, Ireland, Netherlands, and they tested nearly 100 subjects in each of those countries. They used their carotenoid database. They applied the food frequency questionnaire, which is a validated questionnaire used to assess carotenoid intake. And here's what they found. They found that in Ireland, we consume the lowest amount of lutein and zeaxanthin combined compared to other countries. That's because it's not in potatoes. I'm glad I got a laugh off that. And we see here that in Spain, they had the highest amount. And let's look at why, because in this very nice work, they were able to actually track it to the foods that these people were eating. And you can see here that, for example, in Ireland, peas and broccoli, no sign of spinach there in Ireland. We're not eating a lot of spinach at all. Whereas if you look at France and Spain, you can see that spinach would be the main intake of lutein there. So the food matrix is important, the food and its concentration of carotenoids is important, the bioavailability is important, but primarily it comes down to you or your patient in terms of what we're actually eating. We had a look at this ourselves. We have several databases, and we looked at one particular database where we assessed over 800 people. And again, we used a food frequency questionnaire. And the punchline from all this, by the way, is that we are consuming very low levels of lutein. If you look at Ireland, in our study, we see about 1.3 milligrams per day of lutein intake. We'll come on to supplements later. What's in a standard supplement? 10 milligrams, 20 milligrams, 30 milligrams. Is there a need to be taking that much when a normal diet gives you 1 milligram? I have some views on that, and I'm going to take you through it. Kind of takes me to the next part of my lecture, and I said I wanted to speak about mesozeaxanthin, because you'll notice that I didn't discuss mesozeaxanthin from the studies that I've just presented to you. And the reason for that is those studies haven't looked for mesozeaxanthin, they haven't reported mesozeaxanthin. And the reason for that is it's novel and it's quite difficult to do it. But let's see what we do know about mesozeaxanthin. We know that it forms 1/3 of this yellow pigment in the macula. So it's dominated at the center, and it forms 1/3 of the macular pigment. The stereochemistry, you can see it here. You can see the ratio changes. We know from some work done on monkeys that it's likely that lutein, when you consume it in the diet, is converted to mesozeaxanthin. We're looking at that work at the minute because it was a very difficult experiment, understandably. It's very difficult to measure mesozeaxanthin. And while we do think it's likely that it is the case that lutein is converted, I think there's some questions that remain to be answered. There was also some work done in quails. But we've just published a review on this because looking at this and looking at the data, we believe that while the chemistry of it suggests that, yes, if you eat lutein, people via enzymatic reactions, etc., will be able to do a conversion. But I don't think that we can say with 100% confidence that it's wholly and solely generated from lutein. And I think further work is required in this area. And the reason for that is we're not a monkey or we're not a quail. They're not the ideal model to make direct comparisons or conclusions. So work in this area for me absolutely needs to be ongoing. Let's see what we do know about mesozeaxanthin. We know in the chicken retina 47% of total zeaxanthin is mesozeaxanthin. We know in turkey retina 28% of total zeaxanthin is mesozeaxanthin. We know that birds make mesozeaxanthin and concentrate it and other carotenoids in their retina. And this is within the brightly colored oil droplets. So mesozeaxanthin is there. It's in nature. That's clear. And work by Catherine Sheet has shown this very nicely indeed. And in my scientific lecture in the next coming days, I'll be going into this information in a lot more detail because it's a very topical conversation within our field. And by the way, all these beautiful colors that we see in nature, and you can see these images here, are due to these carotenoids. Carotenoids give the world its beautiful color. In terms of food, the first time that this was looked at was by Mioka in '86. And just to try and explain this to you a little bit, this paper, the first isolation of mesozeaxanthin in nature, these look like exactly what they are, and that's peaks. And these peaks are representative of the carotenoids that we're interested in. Without going into the detail, I can tell you that this is what we call a chromatogram. And if we were to take a blood sample or a food sample, for example, we would put it through an extraction. We would run it on a system called a HPLC system, high performance liquid chromatography system. And what we do is we get peaks that have particular heights. And the short answer here is that the height of that peak and the area under that peak is directly related to the amount of that carotenoid of interest. Every carotenoid has its unique retention time, almost like a fingerprint ID. So mesozeaxanthin peak 1 that you see here will come out with that method at the same time every time. So if I took all your bloods and if I measured it on the HPLC, you'd all have different height peaks for these carotenoids because you would all have different amount of carotenoids in your blood, and you can quantify it. So Mioka and researchers did look at this, and they found that it was in fact present in what I would consider less commonly eaten foods, as you can see here, but they did find it in shrimp, and it's just some examples: yellowtail, black bass, etc. And again, the colors, the beautiful colors that you see in the skin, are due to carotenoids. We've been looking at this. This is Katie Marr, one of our scientists, a PhD student in the Macular Pigment group, and she's been looking at this with other scientists in her lab. For nearly 2 years now, we've been looking at foods and different marine products. And we've been testing it because we wanted to retest this. We've looked at fruits and vegetables, and we've looked at fish and seafood. The quick result here is that we did not detect or find mesozeaxanthin in the fruits or vegetables that we tested. The same fruits and vegetables that do commonly contain lutein and smaller amounts of zeaxanthin. We did not detect it. I will say that we didn't focus too much on fruits and vegetables because we didn't expect it to be present in those nutrients. I'm going to present to you, however, just one example of fish analysis that we've conducted where we did find it. And this is the result that we did find mesozeaxanthin in these fish. This is it's actually a picture of the trout flesh. This is an example of trout flesh. And you essentially put it into a solvent that you can extract the carotenoids out of. It all looks very easy. I'm sure Katie's looking at it saying, God, how can he summarize it so quickly? It's unfair. But the work, this is our chromatography, and this chromatography looks quite messy, and that's because it is. These substances are very, very difficult to work with and deal with. But we've managed to get our method to a level that we can do that. Our unique retention time of mesozeaxanthin we can see here. That's matched to a standard so you put standard mesozeaxanthin on, it should come out at that time, it matches. It also has this very unique absorption spectrum which matches perfectly. Okay, so that confirms that it's mesozeaxanthin. And the final step in this identification forensic experiment is that if you add mesozeaxanthin standard to that sample and re-inject it, your peak should get bigger, right? And that's exactly what it did when we did our spike coelution. That peak got bigger. So we've confirmed now, just like previous literature, that mesozeaxanthin is present in these foods. Now let's talk about supplements, because you all make, how many people in this room make recommendations about supplements? Yeah? Most of them. Most people. Okay. So I'm going to talk to you about the science behind supplements a little bit, and the supplements that have been tested in our lab and others. But I'm going to talk to you then about the functionality of these supplements. Here's the slides can go on, by the way. There's so many supplements. We have a visiting young student, and the first job I gave him to do was create 2 slides of pictures with supplements. He came back with 10. There's so many lutein supplements out there. I would hate your job to try and make a decision. But my recommendation to you will be, look at the scientific literature in terms of the supplements that have that testing, from consistency all the way through to functionality. And you'll see why later. So we've looked at supplements. We've looked at many different types of supplements. The first one I'll show you is a supplement common in the UK, MacuShield. You can see here that the measured concentrations of the carotenoids of interest here, lutein, zeaxanthin, and meso, the concordance, so the agreement between what it says on the label and what we found was very, very good indeed. It passed it. You can see there the very nice absorption spectrum of that example of mesozeaxanthin. There's your mesozeaxanthin peak. That's in the second part of our assay. Again, I won't go into that in detail. This is a supplement by Bosch and Lomb, Ocuvite Complete, and again, concordance here is quite good. The concordance between declared and measured. So they said total carotenoid content is 12, and we found it was 11.52. That would be very good concordance. But what we found to be very interesting indeed was that this supplement also contained mesozeaxanthin, and this wasn't declared on the label. And you might ask yourself, how could that be? I mean, surely they'd know about this. Surely they'd be talking about this. Maybe they do know about it. I don't know. But what I can tell you is it's there. It's there in this concentration, 1.22 milligrams is what our calculations show. I'm going to tell you why I think it's there. It's there because it's sourced from Flora Glow. So how this works, let's think about it. How do Bosch and Lomb or MacuVision get a product? What they do is they source a lutein or a zeaxanthin or a mesozeaxanthin from somewhere, right? So DSM, Chemin would be a well-known lutein provider. So they would provide lutein to a lot of the companies that are interested in supplements. And when we looked at the standard of the lutein that you can get off Chemin, we see that it actually contains mesozeaxanthin. And I'm not too surprised about it, to be honest, because if you think of these compounds, it's very, very difficult to separate them totally. Typically where you get lutein, you get zeaxanthin and mesozeaxanthin. They're brothers and sisters, essentially. So they hang around together. So, I mean, it would take a very good experiment, and we've done it to actually purify lutein. It can be done, but it's not. If you think of it, a large-scale production of lutein for supplements that are on the market, it's likely that it's going to contain the other carotenoids as well. You're going to hear today about Arids. Arid started the whole concept around studying nutrition and supplements, and it informed optometry, it formed ophthalmology. And we said, look, given the year that's in it and given that Arids was out, let's have a look at the Arid supplement. So there was a supplement on the market in the UK, Preservision, you may be aware of it. This was claimed the Arid's 1 formula plus lutein. We've looked at this, and again you can see, albeit in small amounts here in this one, mesozeaxanthin is present in that supplement. Arids 2 just published in May. We were all over at the conference. Again, you can see here, again, this is work that Katie has done. You can see here that it contains 0.3 milligrams per supplement. You might ask yourself, does that matter? What does 0.3 milligrams mean? Again, without me going into all the slides, which I haven't available, it does matter. It affects the serum concentration, and it can potentially have an impact, particularly in the context of the Arid study, which was 5 years long, people taking these supplements every day. So in conclusion on that, I think, you know, what is mesozeaxanthin? Where does it come from? Depending on who you talk to, you'll hear a different story. I think it's scientifically fascinating. You know, it's the central macular carotenoid. What we've seen clinically, you're going to see today from Professor Beattie's lecture, etc., in terms of, you know, what it can potentially do clinically. I think we need to understand it more. I think we need to not just accept a very nice study, excellent study done in monkeys or quails. I think the scientists are obliged now to continue the scientific conversation and experiment. I now want to move to the next part of my lecture, and that is to talk about why is macular pigment important. Professor Beattie will speak about age-related macular degeneration and visual function and macular pigment for the AMD population. I'm going to speak about the non-diseased eyes. And this, by the way, is where I think the opportunity is for the optometrist. The optometrist, the first line of eye care provider. What's the job of the optometrist? It's about getting vision right for the patient. Let's not wait until disease is there. Let's do a lot more early on. Let's get busy early. So I really believe this is an opportunity for you. And I'm going to show you why the data supports that. So we're not talking just about stopping central vision loss, keeping vision. We're talking about taking this, what we all would consider as normal vision, and creating high definition. We've termed it supervision in our grant application. Is there a way we can create supervision? So your patient is very different then, isn't it? Your patient is not the 70-year-old AMD patient. Your patient now is everybody else, actually. Everybody else that comes into your practice. Has implications for pilots, for drivers, for sports people. And you're going to see a lecture today, the last lecture from Professor Randy Hammond, which is going to speak about this in much more detail than me. But this is really, really the area. This is really the opportunity, I think, for the optometrist. And let's think about it, why. I'm not going to talk about the antioxidant effect, okay? Professor Beattie will talk about the antioxidant effect in terms of the AMD patient and why that's important. I'm purely going to talk about macular pigment in the context of optical filtration. And isn't that what optometry is about? It's about understanding optics, and it's about optimizing optics, more importantly. And here's why. Here's a cartoon illustration we use. This patient, just picture it for a second, right? 40-year-old male, overweight, eats burgers, doesn't eat peas or spinach, right? It's very possible that that person has no macular pigment. We've measured probably at this stage about 6,000 people, all studies in, all considered. And there's a lot of people, a lot of 40-year-old males and females walking around with absolutely no nutrition in their macula. None. What does that mean? It means they cannot filter blue light in this important part of the eye. And just think of it in that context. Think of macular pigments important in the context of filtering blue light. And we'll talk about blue light. Isn't it a problem for vision? We're going to understand why it's a problem for vision. Let's look at this guy, the 40-year-old marathon runner that annoys us with his smoothie and his spinach for lunch, okay? So this person is very different. And if you measure their macular pigment, you will see that it will be above normal, above average. And you can, that's the other thing to say about macular pigment, guys. It varies very, very dramatically. If I measure everyone in this room, it will range from 0 to 1 log unit. That's a compressed linear measure of yellow filtration in the eye, which is highly, highly variable between individuals. Okay? So why is that important for vision? You know this better than me. You know why it's important. Chromatic aberration, short wavelength light. So blue light is a problem. Remember what I said about macular pigment. It uniquely filters light at 460 nanometers. That's blue light. This pigment that we get from nutrition, that's present in our macula, uniquely filters blue light. Okay? And why is that important? Blue light is focused before the retina, chromatic aberration, right? Out of focus imaging, blur at the edges, patient's not happy with their vision in this context. Okay? So the reality is if we can optimize macular pigment for this, we can filter the blue light in this part of the macula, which we don't need, by the way, anyway. We have no blue cones in our foveola. So we don't know what to do. Blue light causes visual confusion. How do we measure that? Again, I enjoy talking to optometrists about this because, you know, let's think about it. Are we measuring vision appropriately? How many people use contrast sensitivity as a standard measure of visual function in this room? Honestly. So Scott does. How many people use visual acuity as routine? So this is the language of vision. This is the language of optometry. And you know that visual acuity, yes, it's an important measure of visual function, but we're measuring at 100% contrast, guys. That's not representative of real life. So if you want to understand how we can optimize nutrition for vision, and more importantly, the implications of that, we need to measure this right. So it's a very important message. It's one of the learning outcomes I would like to give you today. Measuring vision is important. We've looked at this extensively in our lab for 6-7 years now, working with optometrists at PhD level. You know, we need to measure vision appropriately. Contrast sensitivity, the quick answer here is contrast sensitivity picks up visual function very well. Not just in normal population, in non-diseased eyes, but in diseased eyes, you'll see later in Professor Beattie's lecture. 6-CPD is what I've seen to be a very good indicator of visual function. That correlates brilliantly with subjective reports. So how does the patient feel? Okay. You see, we've published a paper on cataract surgery, and we all know many patients have come in that say, doctor, you know, I'm not happy with my vision. You measure their acuity, what are they? They're fine, they're 20/20 and better, right? But they're not happy, and that's the reason. So contrast sensitivity is the quick answer, and you know why? Because contrast sensitivity doesn't just give you this global representation of vision, it looks at fine detail, so you get a better broad assessment of vision, visual function. So that's the importance of looking at high and low spatial frequencies, okay? High spatial frequencies, of course, you're looking at the fine detail, the small writing. Light scatter. Today is a great example. Blue light again. Let's keep talking about blue light as the problem here, and I'm going to keep saying it. Macular pigment uniquely filters blue light in the absolute right part of our eye. So blue light is a problem. Why is it a problem? Very quickly, light comes down from the sun, light is scattered, right? Why is it scattered? It's scattered because it hits the ozone, it hits particles, it hits clouds, so on and so forth. Short wavelength blue light is scattered more than any other wavelength of light. And that is why the sky is blue, because of that light scatter. So we have this scattering before the lens, before the eye, and then we have scattering in the lens, in the cornea, in the vitreous. So there's this bundle of scattering going on, light scattering, and what does that do? It causes this horrible veil of luminance over a macula that results in suboptimal vision. You can measure it again with low contrast, poor vision. The patient won't be happy. You walk out today, I'll give you another example of blue light and light damage. You walk out today, we're in a dark room, what's the first thing we'll do? We'll all squint, right? We'll all struggle with that. And that again is because of blue light. You'll see later in Professor Hammond's lecture about, you know, blue light and its implication in sport and baseball. You know, the baseball cap was invented to get blue light out of the eye during sports performance. They wear the black under their eyes to reduce glare. So all your patients will suffer with glare. All your patients will be affected by light scatter to some degree. And we have a way to optimize that. How do we do it? We optimize macular pigment. We remove blue light from that central part of the visual pathway. You can also have glare to the point that it causes absolute stress, photostress. And that's essentially where you're blind for a couple of seconds. That's if the intensity of your light gets so high. So there's safety implications here for your patients. And optimizing nutrition with macular pigment is something we can do to help that. I'd like to talk quickly about the safety of nutrition. When you make recommendations, you need to know that it's safe to do so. This was a paper published by Chinese researchers, and the quick answer from this and the quick conclusion is that concentrations tested far, far greater than any of us could ever consume had no negative contraindications or effects in these animal models. There was slightly yellowing of the skin, and that's due to the carotenoid. But a 100-fold safety factor has been applied. 3 milligrams per kg. So I'm 60-something kgs, so you can do the maths. Mesozeaxanthin, in conjunction with lutein zeaxanthin, in terms of its response, was studied first by Professors Bone and Landrum in Florida University. And as I said, in 2006, 2007, we started a lot of clinical trials and experiments looking at mesozeaxanthin. This is our Vision Research Centre. This is where we do all our clinical trials in Carrigganore, in Waterford, in the Republic of Ireland. The Howard Foundation supported work in this area and continue to do so. And the first study we wanted to look at was safety for humans. If we give this to patients, is there anything that may happen that we don't want to happen? So we teamed up with Clayman Clinical Pathology Laboratory in Dublin, and as part of the ongoing supplementation trial, we sent our samples, blood samples, to them for safety testing, and published in Investigative Ophthalmology and Visual Science. You can see that there's absolutely no change in any of the measures that were assessed here. Not even in C-reactive protein, which if you get a cold, for example, that will increase dramatically. The first question we had to answer was, do people respond to mesozeaxanthin? We've explained this morning that it's not typically found in leafy greens, coloured fruits and vegetables. It is in nature, but in small amounts. Probably not, and likely not, let's be clear, enough to get you some into your serum, etc. But what we saw in this study, this was an exploratory study which we published in Current Eye Research. You can see that very quickly the serum increases. You'd expect that. For mesozeaxanthin, it was quite novel. I think Richard and John did look at it in 2 subjects and they found a response. But we did it in the context of a clinical trial. And what was dramatic about this exploratory study, and the reason why it was published with such short numbers, was that we needed to start a debate, and the reviewers agreed that the rate of response that we saw with this mesozeaxanthin-containing supplement was far greater than what we would see with a lutein-based supplement. In short, you can supplement with lutein for 6 months and show very, very little effect. If you look at the time frame here, after 2 weeks of supplementation, we were starting to get significant increases at the center of our macular pigment. And remember, mesozeaxanthin is contained primarily at the center of the macular pigment. So this was a very important finding for us, and it kind of opened the door and stimulated our scientific interest to continue this. This is work, again, from some of Katie Marr's PhD. And the reason why I put this up is I want to point out that the relationships that we're seeing with mesozeaxanthin in serum and subsequently in the macula are very interesting indeed. And particularly when you look at the AMD patient. Now, I told you I'm not going to talk about AMD today, and I'm not. But I wanted to introduce this, that the response that we see to mesozeaxanthin is very different if the patient has AMD. It seems to be much quicker. There seems to be a need for it. There seems to be a very dramatic response. I wanted to put that up. And this is some other work where it proves that point in terms of macular pigment. The difference between the lines there is the difference you see between a response to mesozeaxanthin in an AMD patient versus that to a normal patient. Normal being a patient without ocular pathology. I'm going to take you back to one of my first publications that kind of, I suppose, put me on the macular pigment map. And this was work that I did in over 800 healthy, normal volunteers with absolutely no ocular pathology. So just like the majority of people in this room, no eye problems, everyone healthy, right? So I measured all their macular pigment, and I looked at all the different characteristics that they had. For example, were they smokers? Had they good diets? Had they desirable body fat? And so on and so forth. Had they a clinically confirmed family history of AMD? So this was the basis of my actual PhD work. And what we published in this study was that people with a confirmed family history of the eye disease macular degeneration, decades before the disease presents, so years and years before they will get, and this is the important thing about carotenoid nutrition and nutrition for the eye, guys. If it's to work, it's going to work in a cumulative and a chronic way. It's going to protect the vision over time. It's like there's no point in putting sunscreen on when you're sunburned, right? That's an analogy I will use to explain it to you. We need to do the right things early on and consistently. We found an age-related decline. So as people get older, their macular pigment level drops. And we found that cigarette smokers had significantly less macular pigment. So the conclusion from this is that the 3 most important risk factors for AMD were associated with a significant and independent lack of macular pigment. So your patients that come into you, that smoke, that have bad diets, that have a family history, you know straight away that their macular pigment is less than people without those characteristics. Work has evolved since then, and work from Mark Kirby, and you'll hear from Mark later. He's now working with Macuvision Europe. One of his publications, again in IOVS, looked at the spatial profile of macular pigment. So now we're able to measure the full spatial profile of this pigment. Typically, Everyone said it has a mountain-like profile, so it peaks at the center and decreases in concentration as you move across eccentricity. So to give you the eccentricities, it peaks at about 0 degrees and decreases as you move out, optically undetectable at about 7 degrees of retinal eccentricity. What was very important about this work was that, Mark found that about 88% of the population, normal population again, remember, no eye disease, they were walking around with these typical peaked mountains of macular pigment. However, there was a very clear finding that we also had this central dip in macular pigment. And we've coined this profile a central dip in macular pigment. And we hypothesized in this study that this dip was due to a lack of mesozeaxanthin. Because remember, mesozeaxanthin is located centrally. And it's dependent, if we source it from lutein primarily, that there's some conversion happens. What if you're at-risk patient, your family history patient cannot do that? So this was the hypothesis we put forward. The important thing about this was that we found that these dips were significantly more common in the people at greater risk of age-related macular degeneration. So let's just for a second accept that this is a problem. I don't want a volcano in my macular pigment. I want to have that normal peak. So that's a problem. We conducted a study to see if we could fix that problem. And again, this work supported by the Howard Foundation. And it was a double-blind study, randomized study. We called all the patients that had the dips, and we told them, you have a dip in your macular pigment. We're not quite sure what it means. We want to do a trial to see if we can rebuild that pigment, because we believe it's best to have it optimum. And the majority of those responded and said yes, that they would come. What we did was we sourced 3 supplements. We sourced a supplement called ultralutein. We used MacuShield. And we got a high mesozeaxanthin supplement. So MacuShield would source their mesozeaxanthin from a company in Mexico called Industrial Organica. And we got them to make us a very, very high mesozeaxanthin supplement. Because the research question here was, is mesozeaxanthin on its own very important? Is it better than just having a lutein or a combined formulation? So quickly to show you the results, the ultralutein, which by the way, we've tested all these supplements, 20 milligrams of lutein. So a lot of lutein. And importantly, it was in a soft gel capsule. It wasn't degraded. Okay? So a good lutein product that's important to say, because we've tested, as I said, a lot of products that don't have exactly what they say on the label. So this was a good product. That had no effect on the macular pigment profile centrally, or the patient still had the dip, or peripherally. This is the Industrial Organica formulation, and you can see here that all these eccentricities, so the eccentricities are the location that we're measuring. The central one showed a dramatic increase, a statistically significant increase. So mesozeaxanthin, the high mesozeaxanthin appeared to fix the issue centrally. However, when you look at what the MacuShield formula was able to achieve, you got a really, really dramatic increase here, but also a shift across the spatial profile. So remember what I said. What's the objective of the exercise? It's to increase macular pigment centrally and across its spatial profile. If that is the objective, we've shown here in these unique patients what can be achieved when you have all 3 carotenoids present, as was in this formula. The last part of this question, and I'm coming to the end of my talk now, but the last part of this question is, well, what does this mean for vision? What does this mean for your patient? Bosch and Lomb have been very good and very supportive of research in this area. Bosch and Lomb have invested a lot of dollars looking at their Ocuvite lutein supplement, and we've worked very well with Bosch and Lomb, and we've had some very important findings. There's a common result, however, from those lutein-only supplements. We published a study called COMPASS, which was a double-blind trial where we looked at young normal people. We looked at their visual function. And the quick answer was that we couldn't really enhance their visual function in the intervention group. There was certain individuals that responded very well, and subsequently their vision increased. And when you looked at people in that study that ended up with the highest macular pigment, yes, their vision was significantly better than the people that didn't respond. We wanted to see then, if we have this formula, which we've shown in terms of response is unique in serum and in the macula, what does that do to visual function in our friend, the 40-year-old male, for example? Okay. So we used the ultralutein supplement, we used Macu Shield again, and we had a placebo that was prepared as well. Again, this work was supported by the Howard Foundation. We spent a long time working on visual function. We worked with James Lockman. He's unfortunately can't be with us today, from DIT Optometry School, and James worked with us, and we spent a long time devising the measures of visual function, from questionnaires to assess subjective visual function, all the way up to the absolute contrast test, glare test that we wanted to use. Here's the quick result, and it's quite impressive. You can see here that the Macu Shield group had the significant increase at each eccentricity. You can see it here. But the other thing to point out is the rate of response here was very dramatic. So that's consistent. Remember that very exploratory study I showed you, the very first study we did, how quick people respond to this. That's seen by the depth of this line here. So you get that increase. So enrichment centrally and across the profile of macular pigment was achieved. You can see the group 1 here was better than the placebo, but not much so. That's very consistent with what I've seen with other lutein-based clinical trials. What does it mean for contrast sensitivity? We spoke today about the importance of contrast sensitivity. Why would macular pigment be important for contrast sensitivity? Here's the result. We've essentially a 20% improvement in contrast sensitivity. You're talking about a line and a half on a vision chart. If you look at the Thompson contrast chart, for example, if you look at the gratings, you're looking at going from here to here. Subjectively, we have cases where the subjects report this to match up as well. So this was a very important finding. Glare. Glare for me is the important thing here with macular pigment. I think macular pigment has a big role to play in reducing glare. And again, the message was the same here. At each spatial frequency, remember the spatial frequency and the importance of same, you can see that there was an improvement in the Macu Shield group, and the lutein group didn't show that effect. And this work was published in Investigative Ophthalmology and Visual Science. And all these papers, which I've shown you today, by the way, are available downstairs. If you'd like to take a copy of any of them, our group has made them available. So you can take them away and read them and study them in more detail. That takes me to the end, and it's been a fantastic journey for me. It's been 11, maybe 12 years of my life now looking at macular pigment. I know nothing else, to be honest. But I remain happy to study that, and it's based on this work, and it's based on the support from Bosch and Lomb and the Howard Foundation and the clinical trials that we've been able to do, that Europe has now accepted that there's something very important here. And the European Research Council, who have my primary funding, it's a competitive research organisation under the Framework 7 programme, have funded our group nearly 2 million euros, when you include overhead, etc., nearly 2 million euros to continue work in the area of mesozeaxanthin. And it's important for the normal population. This is this high definition, this supervision. And we're in the middle of that, and some of the PhD students working on that are here today, so you might get a chance to meet with Jessica's here. You'll hear her speaking later. And Quajo's at the back today, so they're working on that study. Professor Beattie will speak to you about this in the context of the AMD population, and we'll learn why this is important for that as well. And these are the 2 trials. So to wrap up and to conclude from my point of view, it was quite embarrassing to say that although I've been studying this for a long time, I never really looked at the data in terms of what we actually consume. And I was very surprised to see that. And I think David mentioned it last year, David Thurman, who works with the Howard Foundation, that we actually consume low amounts of lutein. That is the case. Supplements containing all the 3 carotenoids for us in our trials have shown to be uniquely increased serum concentrations and macular pigment levels of centrally and across the profile. Supplementation with all 3 carotenoids enhances visual function and performance in non-diseased retina. And again, I think that's an important message for you. We now have something we can do with nutrition that you will see. Your patient will be delighted. I'm confident to tell you that. If you use nutrition appropriately, your patient will be delighted. Okay, so there is an opportunity here for optometry. The debate will be ongoing as to, nutrition versus supplements. I absolutely support healthy lifestyle, absolutely support a balanced diet of carotenoids where possible, but I think that there's an absolute need now, given the aging population, given the visual performance challenges that are there, given that we've learned, and you'll see again in every lecture today that this reoccurring theme about visual function. Can we create this high definition vision for our patient? And while doing that, by the way, we're going to protect vision into our later years. So at this, I'd like to finish up by acknowledging and thanking all the scientists, there's many of them, that have contributed to this work. Again, the Howard Foundation, the European Research Council for their ongoing support of me and my group. These are our facilities. As you can see, we're very fortunate to get to do a job we love in these facilities, and we will continue to work in this ever-growing and important area of research. To thank Professor Beattie for his ongoing direction to me and the group and all our colleagues, all the PhD students, because these are the people that do the hard work day in, day out, and without them, we wouldn't have all this important data to be able to present to you today. And here's just some of these students that have worked on the data I've shown you today. Again, particular thank you to Dr. Howard for his, not just his support, but his ongoing scientific contribution to what we're doing in Waterford, and his enthusiasm has to be admired for this area. And David, who supported our laboratory on the HPLC and clinical assessment as well. So thank you very much. Any questions? Yeah, so we have mics, so we're going to use mics so people can hear the questions. And I will encourage questions as well if we have time. There you go.
Thank you. Looking at the contents of the food, you're talking about lutein and zeaxanthin seem to be mainly vegetables.
Correct.
Is it correct that mesozeaxanthin comes mainly from animal livestock?
Yeah,
Fish?
from the debate is ongoing as to whether it does. There's about 5 papers in the literature. One says that it doesn't, and the other 4, including our work now, say that it does come from like fish meat and fish skin. The concentrations in that, I reckon they're low. So if we remember, the hypothesis is that we don't get mesozeaxanthin from our diet in terms of to contribute to our macula, and that why not just take lutein? What we've seen very clearly is that you may be able to get mesozeaxanthin from lutein, but I don't think everybody can benefit from that conversion, and I think that's why we have these dips. So what we have seen then, when you scale that up, we've seen that a supplement, and this was an important thing to test because we didn't know if we could respond to a supplement of mesozeaxanthin. And the answer is we absolutely do, and we do it brilliantly. And you can take these volcanoes and you can rebuild them and you can enhance visual function. If your question is what foods would we recommend, I think the more work needs to be done in that. Katie, I'm not sure if you'd like to comment on the food end of things, but I think I don't eat too much fish. I'm not going to pretend I do, so I don't think I source my mesozeaxanthin from the foods I eat. But I now take a mesozeaxanthin supplement. I now take MacuShield.
And it would be the skin, you said.
Yeah, again, skin. It's in the meat as well, but it's primarily found in the skin of foods, and so obviously, whether you eat fish skin or not is down to personal choice.
That was the question. Yeah.
That was your question. Yeah. So I know you've looked at that, Stephen, as well in terms of the skin and consumption. Great. Can we get another mic, please? Thank you.
Yeah, I mean, the importance of it in the fish skin and indeed the trout flesh is that it is in the food chain. It is in very small concentrations. But don't forget, some of the lutein will be converted to mesozeaxanthin within the retina. I suppose the important thing and an answer to your question really is, if we were to take everybody in this room and put them on supplements, about 85 to 95% of them would increase their macular pigment. In other words, we haven't plateaued out.
Yeah.
Our normal, regular diet that we eat all day is probably perfectly good until your late 20s, early 30s. But we are living well into old age now, and if you want to, our study with Eamon O'Connell showed that your dietary intake, even unintentionally, of zeaxanthin decreases with increasing age. So I do think that if you want to have maximum and optimal macular pigment properties in the modern world, given our lifestyles, hectic lifestyles, that you probably do need to supplement.
Yeah. Have we more questions? Yeah. Just get the mic to you there.
When you put somebody like me, who's 50 and overweight and what have you, on supplements, how long before the patient starts to notice a difference?
In visual function?
Yeah. And how do they notice it?
Well, the question is, how does the patient? And the patient, if your vision gets better, the patient knows it. And we've seen this patients kind of come back and they're very, very happy, both in the normal population and AMD. How would the optometrist know is a whole different question. The optometrist would know by measuring it. And what do you measure? If I had an optometry practice, I would obviously, because I have a keen interest in this, I would absolutely use the whole nutrition area. I would measure macular pigment. We're going to get a lecture later on how we should measure macular pigment, what we know about it. But I would measure visual function differently to what's routine. I would look at contrast sensitivity, I would look at glare. And I can tell you that's the way it's going. That's the way optometry will go. We even see it now in the United States. You know, all these visual acuity suites and contrast suites, you know, everything is changing. How we measure vision has to change. So how would you know it? You'd know it because you'd notice less issues with glare. Vision will become clearer. And this won't fail you. If you're making a recommendation to patients, I can guarantee you this will work.
Over what time scale do they notice an
Yeah,
improvement?
so again, a good question. Everyone is different. The original studies, I'm not sure if we've John Landrum in, or Richard Bone in the room. Richard is here. The turnover of the response, you found that it was quite slow in some of your work, isn't that right?
Yeah, but probably the answer to the question would be ballpark about 6 months.
6 months, but what we've seen is 6 months would be, the literature would suggest 6 months given a standard supplement. We've seen that response to mesozeaxanthin is quicker than that. You know, we saw 2 weeks in the Connolly paper, significant changes in the macula. And from the optical benefits, you'll get the visual benefits as soon as you augment the macular pigment. So they're linked directly, okay? Because as soon as you optimize your macular pigment, you can filter the blue light essentially and reduce the burden that blue light typically presents for vision. Yep.
You mentioned the importance of mesozeaxanthin in the macula. Does it occur anywhere else in the body? And as a result of that, does taking supplements cause any other improvements elsewhere? Yeah,
a very good question. To now, the literature and the scientists, and they'll be here for the next 3 days at a scientific event, we'll be talking about the exclusive location of mesozeaxanthin at the macula only. But just like I've said to you already, measuring mesozeaxanthin is a very, very difficult thing. And I would not rule out, I believe it's going to be in other parts of the body. For now, the conversation is it's just at the macula and it's converted from lutein. That's the exact hypothesis that needs to be challenged because, you know, it could be in other tissues of interest. And it may have benefits. You know, for example, if you just scale it back to lutein, you know, for skin, etc., there's antioxidant benefits, and who knows? But obviously, we're focused on vision in this room. I know Stephen wants to.
Yeah, John, just want to make a comment in response to your question earlier about an obese person. It is probable that an obese person will respond slower because of competition between the adipose tissue and the retina for the supplemental carotenoids. We did a very interesting study, which was just published in the British Journal of Nutrition, where one subject, a member of our group, completely deprived himself of all carotenoids to such an extent that he didn't even eat seasoned sausages for the 2-month period. So absolutely no carotenoid whatsoever in his diet. And all macular pigment disappeared within 2 months completely and utterly. So you do need it continuously, and some of the data I'll be showing will support that. But lastly, you asked a very good question, which was, how does the patient notice their vision has improved? And the truth is, it's subtle, because you're not improving visual acuity, or if you are, just a little bit. You are improving contrast sensitivity, you are improving glare disability, you are improving photostress recovery. So what all the studies are showing now is that it's subjectively perceived improvements in visual function. So the patient will come back, especially if they're anyway involved in outdoor sports, windsurfing, golfing, anything like that, and they'll actually notice an improvement in their performance. They won't notice an improvement in line of vision when they come back into your optometry practice, and they won't read a line better. But if we were to do contrast sensitivity. And as John said, we all speak English and we all speak Schnell and acuity. That's the way we're brought up. But and it's a challenge to all optometrists, is I know that optometrists throughout the UK and the Western world are currently being undermined by the internet. But in my view, this is the fight back, because optometry should no longer be about spectacles. It should be about vision. That's what it should be about. That's what your 4-year undergraduate course is about. And we really do need to rise to the challenge in measuring other aspects of visual performance, which the internet can't compete with you on.
And we have another question here. We have a few minutes, so we'll take it. Yeah. Sorry, you had a second part, had you?
I was going to say thank you. It was a really great lecture. And
oh, no problem.
that was very good.
Has anybody else yet? We have this lady.
You've mentioned safety, but you didn't mention smokers and the hypothesis of risk of cancer.
Yeah, and that's exactly why we wouldn't recommend beta-carotene. And you'll see why today, and this was confirmed in the Arid 2 trial, and Professor Beattie will be presenting that today. But you're right, contraindications, and there's evidence now that shows that beta-carotene consumption in cigarette smokers increase risks of lung cancer, for example. So that's why I would, if the objective of the exercise is to enrich nutrition of the macula, that's why I've always recommended a focused macular carotenoid supplement. Yeah.
Thank you.
Any last question? Yeah.
Well, first of all, thank you again for a very relevant lecture. I don't know if I missed out on any recommendation of a daily intake quantity, but you, on the comparisons that you're making, you seem to suggest that the MacuShield was giving the best overall increase. So you're therefore suggesting that their contents are close to the recommended daily intake?
Yeah.
Or
Steve and I only spoke about this the other day in terms of daily recommended allowance, and there is none, as far as we're aware, for lutein and zeaxanthin. And you know, some people recommend 10 milligrams, 6 milligrams. We recommend 20 milligrams, and we do that based on what the clinical trials have shown us, a combined 20 milligram. And the reason why we're interested in all three is, A, the clinical studies in terms of response have shown optimal response with all three. And it seems to be a number that works very well. Now, I can't say that if you scaled it down to a combined 15 or a combined 10, that you wouldn't have the same beneficial effect. But, you know, we can only go on the studies that have been conducted. And I know Stephen has a view on this as well.
Yeah, I just want to echo what you said. And the current formula of MacuShield 10-10-2, that was informed by previous studies of lutein, which were typically 10 milligrams. So the 10-10-2 formula of MacuShield is 10 milligrams of mesozeaxanthin, 10 milligrams of lutein, and 2 milligrams of zeaxanthin. And that seems to be delivering. But as John said, if you're to stick to the evidence base, if you're to absolutely say, oh, well, maybe if we gave 9.5 milligrams of lutein and 11 milligrams of mesozeaxanthin, maybe it'd be better, fine. But then you'd have to repeat all the studies.
Yeah.
The studies are on the 10-10-2 formula. They're on the MacuShield formula. And that's where the evidence base is, that it does enhance your visual performance, whether or not you have macular degeneration or healthy macula. And we've done plenty of studies with like 12 milligrams of lutein, and we've seen like 25% non-responders. We've seen no effect on visual function. So if the optometrist and the eye care professional is making a recommendation, you know, there's now evidence. There's a bunch of it. I mean, we brought along our publications that we've been working on, you know, peer-reviewed scientific publications, and you can see that there's a lot of information for you there. It's now well known, well understood, and it's a very exciting time for this field. And that's, as I said at the end of my lecture, it's why Europe now have invested in this. They've invested in it because, not just for AMD, they've invested in it from a visual function point of view, you know, safety. That's what Europe is about. It's about what can we do now, you know, what can we do now with research that will essentially save money in the long run. And they're looking at safety for drivers, they're looking at performance, they're looking at nighttime workers, the whole lot. This is where it's at. And that's the promise I've given them, that we have this very important idea that we can really, really continue to understand, and we will. Last question maybe, yeah. Can we get the mic actually? Thanks.
Well, just following on from that, your chart showed a very distinct increase for the first 3 months, and then it leveled off for 6 months. But if you go on to the 20 milligram per day, once you've got up to the level that you were saying, could you not start easing off on the 20 milligrams a day? And does the macular pigment stay there once you've got it back up to the level again?
Again, I know Professor Richard Bowen was the first to publish on that, and he's with us here today and the biological turnover of these carotenoids, again, differs between individual, but you may get, I think there was about a month, Richard, is that right? A month to 2 month biological turnover is what you found in your human trials? And more or less, yeah, but I think people are different as well in terms of how it may happen, how it may respond. I think your point is, can you stop taking it?
Not stop it, but just ease off on the quantities.
So take one every second day?
Yeah.
Yeah, maybe. I mean,
could I just have one more question? I know you said last one. Have you looked at any correlation with macular pigment density and iris color?
Yeah, this is basically we've looked at this in our 800 sample, and I've looked at it in other samples in my American sample as well that we tested, and there's a clear link that light iris color has lower macular pigment levels than dark iris color.
Yeah, on the iris color question, it's well established that the darker your iris, the more macular pigment you have, and it's unsurprising because they have co-evolved in response to the same environmental stresses, bright light.
But again, on that, it's a subtle relationship as well, and there's absolutely, you can have light iris color and have a lot of macular pigment if you do the right things. So how you behave and what you eat can absolutely counter it. But if you take just a large sample and look at it, iris color, there's an association there for sure.
But in response to this gentleman's question about whether
every second day,
whether you could after a while just maintain your plateau, whatever your particular plateau is with less, it's a very good question, something that needs to be explored. The data I'll be presenting, which is for early AMD patients, suggests that you can't, because at 24 months, when they were on daily supplements, and you'll see this data later, the high lutein ones, anyway, actually dropped off.
They did, yeah.
Yeah, they actually dropped off. But we'll discuss that later. But it is something that is worth exploring, but hasn't been explored yet.
The other thing that we've noticed, particularly in some of Katie's work, when we looked at the serum response, what you get is this initial response in blood. And every supplementation study I've been involved in, you get this very quick response in blood, and then it comes right back down. Now, not back down to baseline, but it comes back down. I've seen this in every study. And the reason for that, we believe, is that it's going to other tissues. And I think this gentleman asked, well, is there other place it can go? It may take longer to go into fat cells, different target tissues around the body. So I think you do reach an equilibrium eventually, would be what the data suggests to me. So I think we better conclude my lecture on that, and we'll now go for the next lecture. Thank you very much.